So we're going to talk about our spine registry this morning. We're talking about enhancing clinical spine data capture and testing patient-reported outcomes in participating sites. Our speakers, of course, myself as the chair of the registry effort, John Lesher, who is taking on the lead in content-specific part of the spine registry. Of course, Tom Nabity, who's really been stepping up to help us as also one of our most highly motivated sites in our registry currently. And of course, the lifeblood of our work really is Beth and Kavitha, who've really shown just incredible passion around this effort. It's been such a pleasure to work with them. Looks like nobody has anything to disclose. So for this talk, we're going to sort of outline what we've learned so far in our last year of registry since last time we were here. We're going to talk a little bit about what we want to try and ask the registry to tell us about spine care and physiatry, data collection efforts, our PRO module, and then what we're looking for next year, as well as a little discussion, hopefully engage some discussion with all of you. So I'll kick off. As I said, it's been really a privilege for me to chair this effort along with this committee of really highly engaged members as well. Like I said, John has been taking on a lead on the spine-specific part of the registry, and other members who are notably, of course, Mark Huang from the American Board of PM&R, which is very important that we partner with our board. Of course, Amy Houtro and Theoru, who's also been a leader in our academy as well. What's interesting is that we came here last year, a year ago, with a lot of ideas about what we wanted the registry to look like, about our plan for collecting data, about our strategy. We had a lot of ideas, and it's really great to come here this year with a registry. We have data, we have participants, and we are actually collecting data, and we have some very interesting conclusions that we're starting to be able to have or summarize with our registry data that we're starting to collect. It's early. We've literally just started collecting data in the last few weeks, but it is really a demonstration of how powerful registry data is, the fact that we have raw data over a few weeks that we're starting to collect and to understand a little bit about our spine distributions. Getting back to why we should be participating in our registry, well, for one, I'm really committed and committed with our group again, and I think the organizations are committed to transforming how we look at education and advancement. There's a lot of pressure and a lot of feeling about updating and advancing how we look at MOC and our educational process. I'm really committed to looking at new ways to look at MOC in education. Registry is potentially one of those ways to transform the way we look at how we practice and how we advance our education. And I'm really pleased that a member of our American Board of PM&R is part of our brainstorming effort, and that's a really big signal that our board is actually really interested in looking at new ways to advance our specialty. Of course, it's also a way to look at how well you practice, understand how you benchmark against your peers. Are we doing as well as our peers? If our peers are doing better in certain areas, how do we improve? This is the essence of lifelong learning, is to understand not so much about what we do procedurally, but understanding around the patient-reported outcome of actual outcomes of what are important to our patients, more so than what's important to us. And of course, we need to show our commitment to our patients that we're interested in those outcomes that are important to them. And from a business and strategic perspective, as we face more and more competition for what we do in our various spaces, both in terms of our diagnosis spaces and our geographic spaces, it's going to be important to show metrics of what we're adding in terms of value in our communities, to our payers, to our employers, to those of us who pay for our services, to understand that we are actually delivering quality and value for patient populations. And of course, we need to drive quality metrics nationally for our specialty, and also start to provide a framework by which we can start negotiating with our payers and talking about value. And of course, in advancing our specialty, we need to start to understand and prove the value of what we do, really, as opposed to being a qualitative description of how we can add value. We can start having data to quantitatively demonstrate what our value really looks like in terms of real data. And of course, both nationally, in terms of CMS, as well as our insurers, are imposing metrics upon us. It's incumbent on us to start fighting back and saying, no, this is what we think is important to us in terms of measuring our outcomes. We're going to hear a lot about this more as the talk unfolds today. So just really brief, what's a registry? Well, registry is simply a collection of data. Like a registry, really by definition, is just a collection of data around a specific purpose. And in this case, our registry is a collection of data that describes our patients. And at the current time, we have basically 3 buckets of data. We have buckets of data that describe who our patients are, lists of their characteristics, their features, who they are, what their weight, their smoking status, their employment status. The second bucket of data is their outcome, how they did, what they actually accomplished, and those outcomes are now more standard around what is important to patients in terms of outcome. And then the middle bucket of data is about what we do with them, the most challenging part of the buckets of data, and we'll hear more about that in a few moments. Getting back to the value of the registry to our specialty, as you can see pictorially, there are many dimensions to why being a part of a registry is so important, and I think that's why I got so encouraged hearing from Tom and from John and the other sites why they are participating in sites. Even though there may not be a direct economic value currently, there are many people who are very dedicated to the future, which is clinical research, cost and payment, being part of a new way of demonstrating evidence-based medicine, advocacy in showing the value of what we do to our national playing field, and more importantly, looking at how we advance ourselves as a specialty in maintenance and certification. We are aligning, of course, very tightly to our BOLD initiative, transforming our specialty, part of lifelong learning, research, and publication, preparing physiatry for success, the registry giving members data to inform reimbursement, contract negotiations, and really demonstrating to our local organizations that we either work for or work with to demonstrate our value to them. And of course, we have engaging our practices with each other. We have opportunities for collaboration amongst practices. And of course, most importantly, we want our patient outcomes to improve. We want to do better by our patients. Like I said earlier, I'm really proud about what we accomplished in this last year. I mean, again, a year ago, we were talking about just getting our registry launched. We were discussing our partnership with ANS, which is no longer. We are, and thanks to going on our own, we are able to move much more briskly than we were last year, and we've submitted data. We started submitting data to MIPS. Now, as of 2018, we actually have data. We're analyzing it. We're starting to look at neurorehab as our second registry effort. We're convening a group, start talking about that. And we are just about to launch a patient-reported outcome module, which we'll see as a demonstration of that. And we have successfully submitted MIPS data in multiple practices for MIPS reporting. And we are now looking at larger data analysis methods to start analyzing data longitudinally. So one more slide about that. So like I said before, we have a registry. We have 155 providers in our registry that span 67 sites across the country. About half of them are data pull push sites. The web entry sites are predominantly MIPS and macro reporting, but the other half, the data push and pull, many of those are MIPS reporting, but the majority of those really are those sites who feel very strongly about benchmarking, quality, and about really the idea of advancing our specialty, which is really very exciting for me. So I'll stop talking here and we'll get to the meat of the registry. And of course, John, let's John take away.
Good morning. I'm John Lusher. So now that we have the registry, we really want to put it to work. And that work really comes down to asking questions of the data that we're collecting. Specifically, what are the most common diagnoses that patients are being given, and what is their care like? How many appointments are being made? What type of referrals are being made? And ideally, what type of procedures or non-procedures are being done? The last 3 points on the slide are, however, the most crucial if we want to continue getting paid for our care. What types of care are leading to the most rapid return of function, the shortest time out of work, and the lowest cost? These are also other questions that we're going to be asking, looking at opiate usage across different diagnoses and demographics and how that's affecting outcomes. Just a show of hands, how many people are interventionalists in the room? 2. How many people like doing interventions? 2, okay. And how many people like reporting adverse events caused by their interventions? So part of the registry is to make that type of process or that type of reporting easier and anonymous. It's crucial to providing good care. Additionally, we're going to be looking at how Medicare pays us and the outcomes we provide. And the last point is just taking a more granular approach to the different patient characteristics and demographics. This next slide is kind of a nuts and bolts on how we're actually doing the data collection. Essentially, the kind of work in progress is how we're capturing the treatment that is being given to our patients. So the first part is relatively easy. Patient demographics, we're pulling directly from the EMR. Things like date of birth, gender, race, those are static. We can grab them pretty quickly. Other characteristics, we're also pulling from the EMR, and as well as the PRO is the patient-reported outcome. Things like employment status, BMI, nicotine dependence, those things can change, but they're still relatively easy to pull. The outcomes that we're essentially asking our patients to give us based on their responses to the patient-reported outcomes, that is essentially done by the patient. They're filling that out and then providing it to us. And then the work in progress point, or this is really kind of the crux of what we're trying to document and follow, is what we are prescribing to the patients, whether that's education, non-surgical procedures, medicine management, or surgical referral, and then essentially following that. This is more of a site-specific kind of work in progress. In some sites, it's actually relatively easy for us to document what's being prescribed and ordered. It's much more difficult to finding out what is being done, whether you're in a small group or a large network or academic center. Following those patients outside of your own inner circle is harder and more labor intensive, but it's definitely doable. Hand it over to Kavitha.
So I'm going to go over some data details. How are we capturing the data and what data are we actually looking at? So we're categorizing the way that we're collecting data from sites in the registry in 3 different levels. Level 1, we're calling demographics. That's your basic demographic information. Level 2 is characteristics. So that's when we get into more information on what's really important from a characteristic perspective of patients that are suffering from spine issues and low back pain. And level 3 is outcomes data. And the reason why we're categorizing them in these levels is because it allows participants to engage in the registry in different ways. The more you move up the levels, clearly the more work it is for analyzing data as well as changing potential workflows within your practice and engaging your patients in different ways. From anyone that participates in the registry, if you only want to participate for MOC Part 4 purposes or for macro MIPS type purposes, we will always get that level 1 data from you. And this data is important to us as a specialty at every level, and we can do different things with the different types of data that we do get in the registry. So here's just more details on level 1 data in terms of demographics, your name, date of birth, gender, height, weight, ethnicity, race, things that we can typically easily capture from EHRs. Level 2 data, some of this can be captured from EHRs, some of it will be patient reported, depending on how data is captured in your particular practice. So in this level 2 data, you'll see some areas here like history of lumbar surgery, level of education, employment status that are really important for spine patients, but can also be applicable to other areas as we branch out this registry to other areas of care for physiatry. And then level 3 data is where we look at our outcomes. We're trying to capture data on treatments, and patient-reported outcomes here. So again, this level 3 data is where we really want most of our sites to be, to capture all of the PRO data that we're looking to capture, but we also know this is likely the heaviest lift for most sites to capture data for. And then once you start capturing level 3 data, we start looking into how are we going to capture follow-up data from these spine patients. We'll get into some of these exclusion and inclusion criteria for how we're following up with PROs a little bit down the road when you see a preview of our PRO portal. And now we're going to show you some actual data from our registry.
Okay, so as Dr. Hatzakis mentioned, we have a live registry. We started looking at our data, and this is just a really brief overview of what we've looked at in the last couple weeks. So up here on the screen, you can see it's a 7-month period of time from Jan 1 to June 30th. This included our push and pull data sites. So it was 22 practices, which totaled 63 providers and was about 1,500 distinct diagnosis codes. So then we looked at the top 6 diagnosis codes where most of these patient encounters would fall into. So I'm not going to go through each one, but you can see the top 6 on the screen and the number of unique patients that amounts to. So then we wanted to look at how do these diagnosis codes change over the patient visit. So again, looking at unique patients, what changed here from first visit to 5th visit? So you will see that the numbers significantly decreased. Our assumption and our hope is people got better. The other thought is that we might be able to narrow down what their actual diagnosis was. You will see that there were some changes over time where the 3rd top diagnosis actually moved into the 2nd top diagnosis. And then on the 5th visit, there were a couple changes there. So then we wanted to look at gender and these top 6 diagnosis codes. Overall, there are more female patients in the registry than male patients. Then we wanted to look at age. I don't think anyone would be surprised to see that as age increases, so do the number of patients. You can really see that on your right of the screen. We looked at BMI and these top 6 diagnosis codes. Again, I don't think anyone would be surprised to see that the majority of patients fall in the 25 and higher range for BMI. And then we looked at the smoking status, and we actually didn't really see a change between smokers and non-smokers with their diagnoses. The next thing we looked at was what is the number of diagnoses a unique patient receives at their first visit. So on the bottom is the total number of unique patients that were in this 7-month time period, just a little bit over 12,000 unique patients. Most of those patients fall between 1 and 4 diagnoses at their first visit. The average was 2.4. You will see there were some outliers with 14 diagnoses, 12 diagnoses over on the left-hand side. Now we're going to have Dr. Nabney and Dr. Lesher get into some of their practice data.
Hi, so I'm Tom Nabney. I am a physiatrist as part of a multi-specialty group outside metropolitan Detroit. My interest in getting involved with the registry was an acceptance of the fact that we are moving from a fee-for-service into a fee-for-quality based compensation system. Whether we like it or not, that's the future. And if we don't, as doctors, get involved in determining what are those data points that we're going to be judged upon, somebody will determine those for us. And I'm going to guarantee I won't like theirs better than I'm going to like mine. So that was my motivation for getting involved with the registry. I just emailed and was accepted as a registry participant. So my role here is really to kind of try to give a day-to-day feedback from a private practice standpoint is what our group is, or how our group functions. So looking at our data, Michigan Neurology Associates is the name of the group that I'm a participant in. We have 4 physiatrists and 4 neurologists, some nurse practitioners as well. You can see, what our data ranges are, our total distinct diagnosis codes, and if we go back to previous slides, we can see that ours are not drastically different from the registries as a whole, with the exception of the last one. And we do not manage hypertension in our clinic. I think this is one of those great examples to show that, one, the registry works. It's extremely good at extracting data from our EMR. We didn't push the data, we didn't select the diagnosis, the process just simply pulled the top diagnoses. And our nurses are trained to document hypertension. Why? Because it's a meaningless MAPS and MIPS data reporting agent that we've trained our nurses in order to make sure it's in our documentation. So again, I think it hammers home why I'm involved in this registry in the first place. I don't want meaningless data to matter. I want important data to matter, things that are actually important to me in my practice. So again, the registry works, and these are the sorts of things that we need to figure out, the documentation part of. Again, looking at our changes over time, looking at the different diagnoses. They're not different than the previous slides you saw from the registry as a whole. If you look in particular at our first visit to our last visit on the low back pain, we're not getting 90% people better, I guarantee you that. So my suspicion is what's happening is our documentation changes. From their initial visit, it's a generalized low back pain, then over time we figure out what the diagnosis is, and they move into lumbar degenerative disc disease, or lumbar disc disease with radiculopathy, or lumbar facet spondylosis, or lumbar facet pain. Some of those other more distinct diagnoses, which again highlights the importance of how this registry is going to work is not just based on whoever codes and code however you want. There needs to be some sort of uniform language that we all evolve into so that this data has more meaning. But we're at the beginning stages of it, and if we don't determine how that data is going to be interpreted, what language we're going to be talking, somebody else will figure it out for us. Couple just highlights of, again, looking at how those numbers change over time. All right, I'm done for now. We'll go back to John. Thanks. Yep.
I'm in a large multi-specialty group. Maybe that's a misnomer. Essentially, my group is the largest neurosurgical group in the country. Lots of surgeons. They've been doing outcomes and registry work for almost a decade. So that was part of my interest in essentially bringing PM&R into the mix, because our care definitely has value, and also didn't want the surgeons to dictate to us what we need to collect. Just looking at the data here, again, what you'll see right at the top there is essential primary hypertension. And as Thomas said, that's just the power of MIPS at work. It could also be the North Carolina diet of regular bouts or regular meals of fried okra and pulled pork. But I think it's a testament to the staff doing their work. Does it affect our spine outcomes? That's up for debate. One of the things that we looked at as we were reviewing the data this week is my diagnosis, or our group's diagnoses versus Tom's group. And one of the things that popped out is these are structural diagnoses, not complaint diagnoses. That could be a bias. It could also be based on the type of practice that I'm in. All of the physiatrists, except for one, are primarily interventionalists. And when we are sent patients typically to the neurosurgical group, these patients have been, for the most part, largely worked up. They've received lots of imaging, counseling and/or had prior interventions already done through pain management. So that could be a reflection of that.
I don't think anyone would be surprised to see that.
Actually, before I go on, one of the things that this slide tells me is that when we're collecting data, or it's pushing me to be far more granular and specific on our diagnoses, how do you differentiate lumbar spondylosis from other intervertebral disc degeneration? Those are things that I don't have an easy answer for, but I think if we are looking to push this movement further, we need to be much more specific on how we are diagnosing spine pain, which, as we know, is not the easiest and not always that specific. And again, this is just essentially the data shown over time, and you'll see the diagnoses change somewhat. The visits, at least here in my group, correlate roughly to months. So as you see out to that 5th month, which is roughly 6 months, based on how we collect, diagnoses are dropping off. This was just a change in increase in neck pain, and that could be that my low back treatments were causing their neck pain, or hopefully they were being solved and now they were coming back for additional pain treatment for their neck. Yeah, take it back to Tom.
So the next few slides are going to focus on comparing data. So that's one of the important parts of a registry's function, is to be able to benchmark yourself against other practices, against the registry as a whole. And again, I think these slides hammer home the fact that the registry works. It can do that. The building blocks are there. Now we just got to pick and choose the data points. So we'll go over some of these here. You know, how, in particular, diagnoses and gender, how it reflects. And you can see it's a pretty even distribution. I don't see anything that jumps out. We have one red bar way higher there under the spondylosis without myelopathy, and you'll see that recurrent theme over the next couple slides, and that just has to do with the fact that our practice had an N of 3 for that. So these are percentages, so our percentages are way off because we had a very low N for that diagnoses. The next one, diagnoses and age. And again, you can take a time and just looking at these, there's a pretty even distribution between the different practices. No glaring differences in our outcomes for these different diagnoses and the age distributions, other than that one diagnosis. And then diagnosis and BMI. This is John and I had a little bet whose population was going to be the heavier, and I won that I guess argument, in that the Michigan Neurology Associates, the MNA, has the more obese population than the CNSA in the first slide there. And then John won the next bet, and whose patients smoke more. So Carolinas smoke more than the Michigans. But again, no great glaring differences between the AAPM&R registry as a whole. My practice, MNA, Michigan Neurology Associates, or John's CNSA. How do we capture patient-reported outcomes? That's really going to be a critical part. So, we talked about the different boxes, the different steps. That third box, how we determine the outcome is a big question mark that we're working on with our PRO, and we'll talk to you more about that. And then John had alluded to, it's difficult not to just, we all see it where we prescribe the appropriate treatment, but whether the patient actually complies with the appropriate treatment is another session, and not to mention physical therapy isn't physical therapy isn't physical therapy. What type of physical therapy they had can make a difference. So those are all challenges that we're ready to start taking on. But again, hammering home the part, the registry works. It's a data collection system that can give us data to then analyze and ask more questions on. I got to turn this over here. Okay.
All right, so we've talked about our patient-reported outcome module a little bit before, so now we're really going to give you a preview of what that looks like. As Kavitha mentioned, we do have an inclusion and exclusion criteria for the PRO module. So any patient that is being followed up with for the PRO To be included, 18 years and older, they have to have a complaint of low back and or leg pain, and the pain has to be for 3 months or less. They are kicked out of the PRO module if they've had a prior lumbar surgery, if they are actively being treated for a cancer diagnosis, being treated for an infection, or it's a workers' comp case or a motor vehicle accident. When the patient is entered into the PRO, they will be sent an email. The email will send them over to this module, and they will get a welcome screen from AAPM&R telling them what their doctor is doing, why their doctor is doing it, and give them a little bit of background, and then they'll be able to start the survey. The first page on their survey is going to be demographic information. This information will be pulled over from the EMR if it's there. If a patient calls your office and says, you know, I have low back pain, and you want to send them this survey ahead of time, you are able to do that. So if this information is not there, then the patient has to enter it. Otherwise, if it's there, they'll be able to just look it over, make sure it's correct. If they want to make any changes, they can. And then you as the provider would get a report at the end of the week saying, here are the patients that made changes to their demographics, so if you wanted to go take a look at those. Everything on this screen is required, and it's your basic, you know, age, weight, race, ethnicity, primary insurance, and employment status. Then we get into some more characteristics. So what are their comorbidities? Are they taking any blood thinners? Are they taking any pain medications? Here we get into a little bit of that exclusion criteria. So is this a workers' comp claim? Were they in an auto accident? Have they had any prior surgery? Have they had any prior treatment? And how long has that pain been bothering them? After they fill out that, they will actually get into the patient-reported outcome module, which is Promise 29. I'm not going to go through every screen. Promise 29 has 29 questions. The first couple screens are all going to be the 4 questions that are in each section of Promise 29. So here's physical function. They will get 4 questions for all of these areas on the screen, minus pain intensity. That is what makes it 29. There's only 1 question there. After they finish Promise 29, we're going to have them do the visual analog scale to do their back and leg pain. So they have to fill out this, and then they're done with their initial survey. After their initial survey, follow-up emails will automatically be sent at these time frames, 6 weeks, 3 months, 6 months, and 12 months. They will get reminders if they don't go in and fill it out, up until there is an expiration date on each survey, so they will get reminders up until that expiration date. In addition to Promise 29 and VAS, at follow-up, we will collect patient satisfaction and return to work. Briefly, we wanted to talk about some new registry features that are going to be coming up in the next year, and these features are in conjunction with our technology vendor, FigMD. So I'm not going to go through all of these, but you know, they all have fun, fancy names, and they all do a little bit of different things, but I'll show you a few of them. So Pegasus is our AAPM&R dashboard for the registry. This will help us manage our practices, onboard our practices. We'll be able to see what measures are physicians using the most, and then, you know, we'll be easily able to show people how many people are in there, what does that distribution look like. Unicorn is the new MIPS dashboard for 2019. So you will see, you know, the measure ID, the measure description, if it's a process measure, an outcome measure, a high priority measure, what your numerator and denominator is, do you have any exclusions or exceptions, what are those numbers? And then over on the right where there's that one green bar, that will actually be your performance information. So if it's a CMS measure, this bar will show you your performance based on that CMS benchmark. If it is a registry measure, one of our QCDR measures, it will show your score versus the registry benchmark. And the really exciting one for us is NEVA. It's our patient engagement tool. So this is actually going to be an app that a patient can download from your office, and any PRO they are enrolled in will get sent directly to that app. This app can also connect to any wearable device that the patient is using, or Apple Health on their phone if that's what they're using. That information will then be put back into the physician dashboard. So if you tell your patient, take 10,000 steps a day, you will be able to track whether or not they are actually doing that through this app. And with that, I'm going to turn it back over to Dr. Lesher to wrap us up.
So based on the looks I see on everybody's face, everybody's excited and ecstatic about joining the AAPM&R registry. I'm just blown away by it, so that's awesome to see. But in case you have second doubts or want to kind of shop around a little bit, there are different choices, but I think this slide does a really good job at showing kind of how our registry stacks up against the others. NAS is the North American Spine Society, and the AANS is the American Association of Neurological Surgeons. As I said before, that's a group that I know well. They've been in the registry business for over 10 years. NAS's registry has just started actually this past summer. The easiest thing is like when you're getting into registry, you want it to be easy. Our lives and practices or our work as physicians is difficult enough. Taking on a registry can definitely seem somewhat intimidating. And really the first two things there, EHR extraction, which is essentially pulling data from your EHR, which we're doing, and then essentially sending files to EHR, which is pushing. It makes the job of collecting data far easier. So I really think this is a nice slide that shows that the easeability of this is definitely in our court. Also, when you look at cost, it's also a no-brainer. So I think we have these two other registries beat. Just my opinion, though. And again, this is just kind of a final push here to say that really big data is here. If we don't engage in it and develop ways to use it to our advantage, it will definitely be used against us in medicine. Our registry, essentially, we own all of the data, and we compare it. That's solely under PM&R governance. It's not surgical governance whatsoever. We are not at all opposed to collaborating with surgical societies in the future, but at this point, we really feel it's important that this type of effort be solely initiated and run by PM&R. It's essentially the only registry made by physiatrists for us. And essentially, success is really dependent on widespread adoption. Can I just see a show of hands of how many people are in residency in this room? First 5 years of practice? Okay, good. So this is really, the younger clinician or provider is really who we really want to try to capture early on, because it's going to definitely affect your practice far more than somebody who's in practice for 20 or 30 years. We're definitely not opposed to taking people later in their careers. We want this to be all-inclusive. Additionally, we're not at all opposed to different types of practice environments, whether you're in a solo practice or 2 or 3 partners or multi-specialty. Especially if you're in an academic practice, I encourage you to talk with your colleagues and other attendings and ask what you're doing with regards to the efforts of getting involved in the registry. It's really crucial for the success. For additional information, all week or the remainder of this week and over the weekend, there's definitely additional learning opportunities. If you are having trouble sleeping at night and want to learn more about MIPS and macro, please attend those. But the registry dashboard demos are going to be highly educational, informative, and go over the nuts and bolts of how this actually works on a more specific level. And then there's also focus groups today, later this afternoon, and tomorrow and Saturday afternoon. Those are the websites for additional information as well. Do you guys have any? That's it. So I think we're going to open it up to questions. Thank you.
I had one other comment, if this is working.
Yep.
Oh, here we go. I have one other comment. Just for those of you wondering how hard is this to participate, I think most everybody here can vouch for the fact that I did almost nothing. I made a call from our EMR vendor to the FigMD, hooked up their technical support with our EMR support, and the data just got pulled out of our system. So if you're using an EMR, it's literally, it's hands off. And then I got somewhat involved at the end just trying to figure out the data. But as far as like pushing the data to the registry, I literally did nothing.
You mentioned wearables and linking that with the app or the patient app or whatever. My question is, what kind of biometrics and data are you going to try to capture from the wearables? And what kind of wearables do you expect patients to use?
Yeah, so that is a technology that our vendor FigMD is creating, the app. I do not know of any limitations to wearables. I think it'll connect to Fitbit. I know it'll connect to the health app on the different phones. And I believe anything the patient puts in there. So if all the patient is tracking is steps, that will come over. If the patient is putting in, I took these steps today, I took my weight today. If the patient's doing more within that app, that will get sent over as well. But it's really patient dependent and what that app might capture. So with Fitbit, sleep will be captured if they're wearing it when they sleep. That could be then sent over. But if all the patient is doing is taking their steps, that's all you're going to get.
Another question. I noticed in the tables here, we showed how the different kind of diagnosis and how they faded over time. I don't know what that really means, because if I have a diagnosis of radiculopathy or something else like that, and it may disappear over time, but there may be other conditions that I have that will be continuous. I'm a little confused, just because, is that a reporting issue? Because a lot of this information is going to be maybe captured on the initial patient encounter, and after that, are you continuing to capture that? I mean, I don't know what those data mean.
Yeah, so that diagnosis is being captured. You're following that patient longitudinally, and so we can't give you a definitive answer on what that's happening. It's just meant to show that we are tracking it. That patient could be going to surgery, they could be lost to follow-up, they could be getting better. And that's kind of, as the registry effort kind of matures, is trying to find ways to put a stop point on that diagnosis. So if that radiculopathy does get better, the person's back to work, then we say, okay, hey, we've reached maximum medical improvement, or there's a potential branch point where they do go to surgery, or they're lost to follow-up. So it's a great point. It's just in the early parts of trying to can we follow this diagnosis over a 6 month, or at least in my practice, over a 6 month time period.
I don't know if you guys feel it.
I'm Hillary Stevens out in California. Fantastic work to see where our field is going. I've got my gray hair. I've been in this field a long time. 2 questions. Do you have the capacity for new variables as research comes out? For instance, there was a recent publication by Kaiser looking at a large primary care practice, and they were able to identify those people with low back pain that didn't get better based on a kind of psychological profile. So new variables may come up. So how are you planning for that possibility, number one? And number 2, don't you get overwhelmed with all this data? This is a humongous data set. Thank you.
That's a great question. That's a great points. I wanted to underscore that a lot of the criteria that we were talking about today, especially when Beth was talking about the inclusion criteria, time intervals. This is a pilot, and so we constrained this pilot for a reason, to make it workable. So our target population was small. Our target time interval, 3 months, is short. So we wanted to keep it constrained so we could learn more about the process. And learn about the variables. So in that vein, the variables we're collecting, this is a pilot run. And so we may find that we can't get people to fill out the pros, for instance, in a year, and so we may have to modify that. And also, there's new papers coming out on employment status and underemployment versus full employment. It used to be a binary variable. Now we add some nuances. We may want to update that as new literature comes out about underemployment due to back pain, for instance. So the answer to your question is yes, we're going to evolve the variables. We hope to engage academic sites. We just had a big meeting with a large academic center on Friday to understand the needs of academic sites and potentially to engage them in adding modules for academic purposes as well. So the answer is very much yes. It is a work in progress. This is our pilot, and we're really learning about a lot of things right now. We're learning about sites. We're learning about our capacity to analyze data. We're learning about what we can collect out of EMR and all the variability from one EHR to the next EHR. And yes, there's a lot of data. And thank God for Beth and Kavitha and the amount of time they spent looking through and making sense of the data. It's a huge amount of data. And as we get further along, we are going to be looking at analytic capacity, probably hiring people to build an analytic group to do analysis. FigMD is collecting data very well, and they're warehousing it, but the actual analysis part is an entire science in and of itself. So yeah, we're going to be learning about that as well.
Just to add, I think the study you were referencing was looking at the Keel Start Back questionnaire, which is a psychosocial assessment when people come in to get a assessment on if they're potentially depressed or how encompassing their pain is, and so then they were stratifying their care from that. And so we have looked at that assessment tool as well. At some point, we could be using it too.
Yeah, I think your question highlights the importance of why we're doing this. Because if we want to have any insight or say on the variables that are important to our patients, we need to do this. Otherwise, if we don't, we'll just let somebody else figure out what those variables are, and we'll have something like MIPS or macro, what we have right now, which really don't mean much to physiatrists. But that's what we're supposed to report. So that's why we want to participate. That's why everybody should participate, so that we can actually have a say in what variables matter.
So I have a couple questions. The first comes back to the question about when diagnoses disappear. Is that because you're seeing a person on the initial encounter, you give them a diagnosis of something, you see them 3 months later, and you no longer put that diagnosis in? Is that why it disappears?
No, I put it in. It's being put in. That person could be lost to follow-up out of my practice. They could be seeing a surgeon. But
so if you see the patient on day one and you give them facet pain, lumbar facet pain, and you see him again on 3 months later, you're still putting in lumbar facet pain, but it's disappearing, or at 3 months? Or?
No.
It's falling off the first floor.
Yeah. If they are not complaining of that pain when I'm seeing them in follow-up, then I'm not putting that diagnosis on there. Correct.
And that's why it's disappearing, because you didn't put in the diagnosis code.
First, second, third.
Yeah.
Exactly.
Okay.
And we're hoping that a lot of sites, John's site is an exception because they're more structurally focused. Most of us start with low back pain or sciatica or something like that, and then that diagnosis either disappears or goes down to past the fourth diagnosis, because now we're talking about a structural thing like spondylosis and spinal stenosis and lumbar facet pain, and that then drops below the fourth diagnosis. And now the structural diagnosis that we proved now ascend to the higher slots.
And then that takes me to my third question. But real quick, my second question is, you're asking for a lot of data from the patients in multiple time periods. What's your response rates? Are they actually filling it out?
We're not there yet.
Not there yet.
Actually, the PRO is the patient-reported outcome. We're all testing it right now. And we're hoping for launching in first quarter next year. Okay. And we'll have some more data. But yeah, that's a big open question of compliance, and we don't know what that's going to look like. And we're hoping we can motivate people, but we're going to learn a lot about that aspect.
But to answer your question, I think it's a really good one. It was really daunting to me. Before I started doing the registry, before I came involved in the registry, I was just collecting data on my own, just to see, how are my patients doing. And so I was doing the oswestry, the Keel Start Back, and then the Euroqual, which is a lot. And I think it really comes down to the provider. If you spend 20 seconds with them and say, hey, I really want to follow your care, and these metrics are really important to me, patients do it. So it really comes down to taking 20 seconds, a minute, making sure that your secretary is on board, your medical assistant's on board, everybody's on the same page. They're all promoting it. So it is daunting. The promise that we're doing now is nothing like what I did in the past. It's far easier. If everybody's on the same page promoting, it is easily doable. And then the biggest thing is, as technology advances and you can make a video of your face saying like, "Hi, Mrs. Smith, it's the 3-month follow-up when I last saw you. Could you please fill out this?" If your face is there, the vast majority of patients, or if it's something that's personalized from the physician, the follow-up on data is enormous.
Okay.
Maybe your face, which is mine. But I think that's one of the things we've learned is that really talking to our patients about the fact that what we're collecting the data-wise is actually important to their care, not just in research, but also by sitting down and saying, "Hey, I looked at your data, I looked at your outcome," and somehow integrating that and making it important to their care, I think goes a long way in them doing it.
Okay. And so my biggest question is, as we all know, as you've mentioned, low back pain is challenging to figure out, and I think the reliability is horrendous. So if someone comes in with low back pain in this room, they're going to get 10 different or 20 different diagnoses.
Or 300.
Or 300. Just in this room alone. So I wonder, I know when I first started practice, I tried to be as specific as I could, and now as I've gone through it more, I've become more diagnosing people with low back pain. I know personally, I'm not going to believe if this comes out to say 25% have lumbar spondylosis. I'm not going to believe that 25% of our patients have lumbar spondylosis. I'm going to believe that 25% of the doctors said the patient has spondylosis. So I wonder, would it be more useful, and even can we just call it low back pain? I don't know. What do you think about that?
That's a challenge. I think this is a bi-directional effort, right? I mean, I think that we're going to have to have some agreements about when we call something lumbar facet-mediated pain, that we ought to have some agreements on what that means. I did a facet injection. They had X amount of pain relief within X amount of time. Thus, they're proven to be facet-mediated pain. And I think that's a work in progress. But I think if we're going to have any meaningful data, we're going to have to agree to what it means we put that structural diagnosis down on the sheet, and have an agreement that when we first see the patient and we haven't proved anything, that we try to resist the temptation to put a structural diagnosis unless we somehow prove that that's our cause of pain generator. So that's going to be part of the effort of the believability will depend on how much we'll work together in those diagnoses.
The problem is that that's not going to happen. If this becomes widespread and you have thousands and thousands of doctors, I mean, there's going to be thousands and thousands of opinions. And I think the best example I tell our residents is that if you look at the lumbar facet prevalence data, it ranges from 6 to 94%. And of course, some of those studies are higher quality than others, but nonetheless, it's nobody has it or everybody has it or somewhere in between. I think that's going to be the biggest challenge with all of these. And so,
Assessment on if they're potentially depressed or how.
Question about how all this is going to feed into MIPS, and also want to ask you, who's the target market for this registry? Because a lot of physiatrists participate in large group practices or in a hospital setting, and they'll be reporting, for MIPS purposes at least, under the TIN of another group or whatever the case may be, and that group may have its own reporting requirements in terms of what it reports for MIPS and MACRA.
Yeah, so while our registry can report MIPS, you don't have to report MIPS through our registry if you don't want to. So that answers your second question. Your first question, how it all fits into MIPS. So as a QCDR, a Qualified Clinical Data Registry, CMS has given us the authority to create our own measures that can be reported for MIPS as long as they approve those measures. So we have 13 of those measures in our registry right now. 8 are focused on spine, 5 are focused on neuro rehab. We have to re-up that every year. So we have to reapply, we have to have our measures reviewed again. If we want to introduce new measures, we have to do it during that application process. And then we have 23 general MIPS measures in the registry. So if someone wants to use this for the PRO and for MIPS, they can pick any of our 36 measures to report. That dashboard I showed you looks similar to the current dashboard we have. You can see your benchmarks. You can select the measures you want to report based on those benchmark estimates we're giving you. And that is all. Once you select everything, you sign off on it, we send it over to CMS for you. If all you want to do is the PRO, you don't have to touch those measures. What we're hoping is through the PRO, we can start to create some new measures for the MIPS program that will be approved in our QCDR. So right now we just have those 13, but in future years we are hoping to create new measures that will touch on the work we're doing with the PRO and the low back pain patients. And I think those were your two questions. Did I get it?
I also asked who's your target
Oh,
market?
target.
Everybody.
Everybody, yeah. I mean, we're not discriminating against anybody. I think Dr. Lesher said it, you know, old, young, solo practice, huge institution. You know, we are the only physiatry-specific registry, and so we want all of the physiatrists in it.
Let me do one quick one. Which of these different groups, which types of physiatrists do you think have the highest probability of participating in something like this?
Currently, I will say it's solo practitioners that need help with MIPS.
Yeah.
So Mark Wong, I'm over at Shirley Ryan. First off, great presentation. That was excellent to see, especially your patient-reported outcomes. So I was going to answer your question too. So we're a large organization. We use our EHR to report for all our MIP stuff. If you care to, I'm going to do a shameless plug because I'm part of the registry committee. Plus, we're going to be talking at 2:30. But we'll go in a little bit of detail. So I'm strong looking at it. I'm actually going to be like totally leaning hard on our leadership to say, let's do it for next year. And we're actually thinking about it. So even though we use our HR to report, one of the advantages, the distinct advantage is now you can choose other quality measures to report on. They're much more relevant. Like, I hate telling my practitioners, okay, and I'm going to show you the stupid slides that we do for like some of the things that's somewhat relevant, but hypertension and fall risk is, yes, it's relevant, and some of the cognitive assessment, but we haven't quite tailored it quite to what we want. We just did it just to satisfy MIPS for now, and then later to do that. But this allows us to report on measures that are much more relevant to what we're doing. So it allows us to do that. Plus, it satisfies a lot of things in improvement activity. So if to satisfy a portion of your improvement activity score for MIPS, guess what? There's a lot of QCDR stuff that you can actually tap into using this. You can check, it's like killing two birds with one stone, which is fabulous. So there's an ability to do that with choosing this method of reporting. Third, you'll see in 2019 the proposed rule, which is probably going to go through as is, which is very sad. There's a flexibility now in our reporting for quality measures. So previously, you could report on like just one method. So it could be claims or registry-based, could be registry-based, could be claims-based, could be EHR-based. Now you can choose more than one reporting mechanism, which is great. So that's our in to like actually use the registry. And then the last thing, which is future down the road, is CMS has actually heard about the issues and complaints about the measures not being specific. So they're actually trying to change that, believe it or not. So they're actually listening to us, and actually I was in on the committee for doing that, so it's great. So we've actually, AAPM&R is actively involved with trying to get people in on this. So I've been involved. There's another person who's potentially going to get involved with another committee if they get the nomination goes through. But CMS has heard us. Rehab actually got the most suggestions for new measures for development. Now, whether something comes out of that is a good question, hopefully. But third, the other piece is that patient-reported outcomes and joint decision-making are big pieces for the future of quality measures and outcomes. So anything that's patient-reported, guess what? That is the future for how we are going to be measured. So we have to figure out a mechanism, so these guys are doing it now. You got to make it accessible, and clinicians have to promote it. So your question of your skepticism about how do you get people to do it? Well, in studies showing for patient portal enrollment, if the clinician's like, hey, I'd really like you to enroll in the portal or do this to help us with communication, they enroll more. So same process with patient-reported outcomes, you just promote it. You just say, hey, I'd really like you to fill us. This really helps us tell how you're doing. Or maybe, hey, use your Fitbit word at night. I want to see if you're sleeping better in addition to your step count. So these are just kind of things in the future as far as, what you can do. But this would be super cool to get this kind of data, the patient-generated health data, to actually get in the system. Because, to me, the hardest part for rehab is justifying what we do. And it's very vague. we can say we do function. Okay, how do you measure it? There's lots of different ways to measure. How do we do ability? However you want to word it. But you can measure step count. You can measure sleep. You can measure where they go in GPS. As much as you may hate Google tracking you, maybe that's a good idea. Maybe your outcome measures how far you leave your home, right? So it's kind of stuff like this. If we can get that stuff in the system, that'd be great. And yes, we're going to have issues with data variables and how do you want to define them, and the whole issue of the diagnosis drop-off as maybe you drop back pain because it's no longer an issue. We'll hopefully be able to figure that out. I think we will. But the bottom line is I think this is a great opportunity for our, and I'm totally trying to get our leadership to buy in for this. So Beth is going to be glad to hear that I'm going to be pushing that, and we're going to try and get a quote from AAPM&R about our, practice, the hospital going in on the registry. So that's what I'd like. Yeah. Considering we got 2 people on the registry committee from Shirley Ryan, I think we can lean enough. So hopefully we got enough to be able to do it. But yes, they're probably like shooting me right now, like the Shirley Ryan people. But yeah, I'd really like to advocate for that. What's that?
I also just want to add that, in rehab, some work that I've been doing with my colleagues is in rehab, we look at the whole patient. And we've come up with a system, and we're reporting results on an RCT on care coordination in VA for Parkinson's disease, where we look at the patient, what are domain 1, the medical issues, your lumbar stenosis, domain 2, what are any mentally related issues, depression, whatever, PTSD. Number 3, what now is their functional ability? Because that depends on your domain 1, your diagnostic burden, domain 2, your mental abilities. So domain 3 is your function, and then domain 4 is your environment. What the heck is going on around you? If there's a husband at home that's alcoholic, that's beating up the patient, and you pick it up, you need to focus on that. And I think we in rehab were trained to quickly do the scan of all 4, and I think that's what makes us special. So I just want to plant a seed, and I'll be shameless. I've been asked to present this Saturday in session 518 as a way of thinking about rehab. And we use this framework in studies of rehab. And we arranged the variables, the PT, OT variables, by these 4 domains, and it worked really well, and we got it published. So I just want to share that idea of how do we capture this person-centered, person-focused whole picture in PM&R. And I look forward to following your work. Thanks.
For those of you, I'm not going to present or do anything shameless, I don't think. I do have a couple of questions. I'm Dr. Nelson, and I work here, and I work with a large organization with primary care. So if I missed it, sorry I'm late, I had a hard time finding the room. I apologize. Are you guys hooked up with any primary care groups? That's one question. Second, are you working with the VA? And if not, I want to know if we're headed that direction. And just compliment what you said. That's exactly, I think, where we're headed. So I think this registry is right on target for PM&R to integrate and just burst out. So I would like to promote that we continue that direction and not stay focused on too many details and go broad.
Yeah, so at the moment, we're not connected with any sites that are showing us data from primary care, but as you know, that's where the specialty vision is going.
Yes.
So is that where we need to go? Absolutely. And as we get more institutions engaged with us that have those workflows in place, that can all be captured. We are thinking about adding a question saying if your patient was referred to you, by whom, so we can try to capture that for some of these smaller specialty practices who may not be connected to primary care in terms of EHR, but we may be able to capture it that way. But absolutely, I mean, we have to go there and we have to get there for the specialty vision, 100%. So we'll call you up. Maybe trip to Alaska's in our books.
Okay, great. What about the VA? Are you?
We are not connected to the VA, no.
Yeah, our organization works with both. So the VA, because we don't have facilities in Alaska for a lot of the veterans, we also encompass them through our Native American work. So the complaint-based, finding the data through complaint-based is really important for our groups
Right.
because they're not going to go to facet-mediated. That's
Yeah.
a long ways down the line. And we also have a higher predominance of spondylolisthesis in Alaska in the Native American population, which is also these structural changes are now coming out. So I'd like to kind of say broad but go detail, but how we do that. And just compliments to all of you for all the hard work that you've done on this. I'm really excited about it. So.
We have actually got the most suggestions for new measures for development. Now, what's some of the good questions?
Okay.
Hopefully.
Thanks, everybody, for coming.
Thanks.
Thank you.